everyone, my name is Taylor Simpson, and today I'll be presenting on pulmonary arterial hypertension on behalf of myself and Melissa Reynolds and Veronica Ziola, and we are part of the nursing program at Mount San Jacinto College. Before we begin, I will be reviewing the objectives for this lecture, which will be giving us a framework of understanding for the presentation. Our first objective is to review the pathophysiology of pulmonary arterial hypertension, which answers the question, what is it? Our second objective is to identify the 5 groups of pulmonary hypertension, which answers the question, who gets it? Our third objective is to discuss the diagnostics of pulmonary arterial hypertension, which answers the question, how do we diagnose it? Our fourth objective is to understand the signs and symptoms of pulmonary arterial hypertension, which answers the question, what are the signs and symptoms? Our fifth objective is to list the 4 classifications of pulmonary arterial hypertension, which answers the question, how do we recognize signs and symptoms? Our last and sixth objective is to describe the treatment, prevention, and education for patients with pulmonary arterial hypertension, which answers the question, what can be done about it and what can be done to prevent it? We are hoping to accomplish all of these objectives by the end of the presentation. Next, we will be discussing the pathophysiology of pulmonary arterial hypertension. Pulmonary arterial hypertension is a progressive disorder characterized by abnormally high blood pressure or hypertension in the pulmonary artery, the blood vessel which carries blood from the heart to the lungs. This occurs when most of the very small arteries throughout the lungs narrow in diameter, which increases the resistance of blood flow through the lungs. To overcome this increased resistance, blood pressure increases in the pulmonary artery and in the right ventricle of the heart. The increased blood pressure can damage the right ventricle of the heart and lead to decreased blood flow through the lungs, resulting in poor perfusion and gas exchange in the body, causing hypoxemia. The stress from the increased pulmonary pressure backs up into the right ventricle of the heart, causing hypertrophy. The continuous workload of the heart causes right-sided heart failure, otherwise known as cor pulmonae, as demonstrated in this picture. Unfortunately, the commonality of these symptoms, patients do not receive a diagnosis until late in the disease process. By the time this late diagnosis occurs, the heart and lungs have already sustained significant damage. The next thing we will be discussing is the 5 groups of pulmonary hypertension. The first group of pulmonary hypertension is known as pulmonary arterial hypertension, which is the main topic of our lecture today. It is otherwise referred to as PAH, and this term is used explicitly for this group. This primary group is then divided into 4 subgroups with different causes. The first subgroup is where it's a rare disease, otherwise known as idiopathic PAH. The second subgroup is where it's inheritable. Genetics cause it to be passed on to one's children. The third subgroup is where it is drug or toxin induced, usually caused by methamphetamines, cocaine, or fen-phen. The fourth subgroup is when it's associated with other systemic diseases, such as connective tissue disorders, lupus, HIV infections, and congenital heart disease. The second group in pulmonary hypertension is where it is caused by left-sided heart disease. This group is characterized specifically by disease of the left side of the heart. Initially, the pulmonary arteries are healthy. However, the passive elevation of pressure in the pulmonary arteries occurs to continue perfusion. Unfortunately, over time, chronic left-sided heart disease can lead to changes within the pulmonary arteries. The third group in pulmonary hypertension is caused by lung diseases. This group is classified by the correlation of many diverse diseases which interfere with the lungs or the control of lung function. The 2 most common diseases in this group are COPD, which leads to emphysema and chronic bronchitis, or lung diseases that lead to scarring in the lungs. The fourth group is where a blood clot either launch into the lungs or develop in the lungs, which cause pulmonary hypertension by blocking the blood flow through the pulmonary arteries, as seen in this picture. The fifth group of pulmonary hypertension is where there is a number of other health conditions which lead to pulmonary hypertension. The mechanisms of these diseases are poorly understood for the illnesses in this group. And typically, therapy is oriented towards improving the underlying disease cycle. Examples include hematological disorders, systemic disorders, metabolic disorders, and other rare diseases.
Diagnostics include a chest x-ray. This can detect enlargement of the right ventricle of the heart. An electrocardiogram, it can also detect enlargement or strain on the right ventricle. The doctor will most likely order an echocardiogram, which can determine the size and thickness of the right ventricle, as well as to measure the pressure in the pulmonary arteries. A right heart catheterization will confirm the echocardiogram's diagnosis of a pulmonary hypertension. This test allows the physician to measure the pressure in the right ventricle of the heart and the main pulmonary arteries. Right-sided heart catheterization showed increased elevated pulmonary pressures higher than 25 millimeters of mercury at rest or 30 millimeters of mercury during physical activity. The pressure in normal pulmonary arteries is 8 to 20 millimeters of mercury at rest. High-resolution computed tomography or CT scans are also used to diagnose PAH by ruling out other conditions such as emphysema, bronchitis, and interstitial lung disease, pulmonary embolism, infarction, and vascular and pericardial malformations, but does not show changes to the pulmonary tissues. Ventilation, perfusion scan, and pulmonary function tests show reduced functional pulmonary volumes with reduced diffusion capacity. Some signs and symptoms of pulmonary hypertension include shortness of breath, or dyspnea, fatigue, syncope, chest pain, tachycardia, palpitations, and leg edema. Since many of these signs and symptoms are so similar to other possible diseases, there is usually a delay from disease onset to diagnosis. Next, we will cover the classifications of pulmonary hypertension. The pathophysiology of PAH affects the pulmonary arterioles and capillaries and the alveoli, where gas exchange occurs in the body. Therefore, the severity of impaired gas exchange is how this disease is classified. No limitation of physical activity. In the first class of pulmonary hypertension, activities for the patient does not experience any dyspnea, fatigue, chest pain, or lightheadedness. Therefore, the patient is diagnosed solely through tests, including pulmonary function test and right-sided cardiac catheterization. No manifestations at rest in the second class of pulmonary hypertension. However, mild to moderate physical activity, a patient will experience induced dyspnea, fatigue, chest pain, or lightheadedness. Slight manifestations at rest in the third class. Minimal activity will induce dyspnea, fatigue, chest pain, or lightheadedness. Dyspnea and fatigue present at rest in the fourth class. Dyspnea and fatigue are present and the patient is unable to carry out any level of physical activity without inducing dyspnea, fatigue, chest pain, or lightheadedness. Manifestations of a right-sided heart failure are apparent, such as edema, engorged neck veins, and enlarged liver. Although there are no treatment for pulmonary hypertension, there are medications that can help slow the progression of the disease. Early diagnosis and initiation and adherence to therapy can help the patient maintain quality of life and improve their mobility. The regimen is often complex. It takes some time to find the right combination of treatment options and requires extensive follow-up care at a center that has a PAH program. There are commonly two types of medical treatments, pharmacological and surgical. However, if PAH is caused by another condition, that will be treated first. Pharmacological interventions are aimed at opening the blood vessels in the lungs to improve blood flow and reduce strain on the heart. These medications can be swallowed, inhaled, or infused continuously, giving patients many options for their treatment. The medications include vasodilators, GCS stimulators, high-dose calcium channel blockers, warfarin, digoxin, diuretics, and oxygen therapy. The main medication used is prostacyclines. These medications replace the endogenous prostacyclines that patients with PAH for some reason do not produce in sufficient quantities. They are normally produced in the endothelial cells and work directly on dilation of the pulmonary vessels, prevention of platelet aggregation in the pulmonary circulation, and prevent fibrosis of pulmonary vessels. Another medication is endothelial receptor antagonists. These block the endothelium produced by the endothelial cells that cause vasoconstriction. Surgical management includes atrial septostomy, which is used if medications do not control the symptoms. This is an open heart surgery in which the opening is created between the left and right atria. This helps alleviate some of the pressure coming from the lungs on the right side of the heart. But the best treatment option is a lung or lung heart transplant. This should be done early on to avoid extensive damage to the right ventricle. These are all ways to medically manage PAH, but another important tool is educating the patient and family. Discharge planning and patient education should begin at administration because a comprehensive care team will be necessary for the care of these patients. Patients who are diagnosed with PAH should find a health care provider who is experienced in treating this condition, or at a center that specializes in PAH may be a better option if available. Patients with PAH should see their doctor frequently and contact them immediately if they are experiencing any changes in their health or worsening of their condition. This is a serious condition and patients should know to call 911 if they experience any of these symptoms. Other reasons to contact the provider would be if the patient has a fever, if symptoms are affecting activities of daily living, if there is joint pain, swelling, stiffness, clubbing of the fingers or toes, or for any other questions or concerns. Patients should be educated on light exercise routines appropriate for their conditions. Patients using prostaglandins should be aware that they cannot abruptly discontinue the medication due to risk for rebound PAH, which can cause right ventricle failure, shock, and cardiac arrest. Patients who are prescribed continuous infusions will need to be educated on how to use the pump and assess their IV site. Patients should be advised that some of their medications are high risk and should be handled with care. Traveling to higher altitudes are not recommended. They should also be encouraged to participate in a pulmonary rehabilitation program and should be informed on the importance of a low-sodium diet. Educating the patient and family on adverse reactions, what symptoms to look out for, and when to call the doctor help increase compliance with the regimen. Because the medications can be expensive, social workers should be involved to help the patient acquire resources needed to ensure they have the medications they need.
NCLEX question number 1. The nurse performs a summary of the client history as part of a clinical assessment. The patient is experiencing dyspnea, fatigue, chest pain, and lightheadedness. Which comments from the patient on their history tells the nurse the client might have pulmonary arterial hypertension? Select all that apply. A. I see a lung doctor for my emphysema. B. I have this disorder where my blood's not normal. I get these painful attacks. C. My father died of pulmonary hypertension. D. My doctor told me the left side of my heart's too big. Or E. I experience chronic blood clots. Pause the video to check your knowledge. The answers are B and C. Pulmonary arterial hypertension can be caused by 4 main routes: unknown reasons, genetics, certain prescription or illegal drugs, and other health conditions like HIV, lupus, congenital heart diseases, or sickle cell anemia. Emphysema, left-sided heart conditions, and chronic clots are all different forms of pulmonary hypertension. NCLEX question number 2. The nurse is creating an education plan for a patient with a recent diagnosis of PAH. Which teaching topics should the nurse include? Select all that apply. A. Call the health provider for a weight gain of greater than 5 pounds in 1 week. B. The medications will control all the symptoms of the disease. C. The importance of smoking cessation. D. Pulmonary hypertension is a curable disease. Or E. Treatments aim to slow the progression of the disease. Pause the video to check your knowledge. The answers are A, C, and E. Smoking cessation is important for a client with pulmonary hypertension because smoking is an irritant to airways and it has vasoconstrictive properties. The client with pulmonary hypertension should be taught to monitor daily weights and for increasing edema because of the risk for excess fluid volume. The client should be instructed to avoid contracting an upper respiratory infection if at all possible. Medication adherence is very important to teach the client with respect to disease management, but there's no guarantee that medications will control all the symptoms of the disease. Pulmonary hypertension is a chronic progressive disease. The most effective long-term treatment for pulmonary hypertension is heart and lung or lung transplants. NCLEX question number 3. The family member of a patient with a new diagnosis of PAH asks, how could this have happened to her? Which of the following statements would the nurse make? A. This disease is very common and usually happens in young women. B. This is a very rare disease. The doctor will be able to tell you exactly what caused her condition as soon as he figures it out. I'll have him come talk to you guys when I see him doing rounds. C. If she has been around anyone coughing lately, that could be how she contracted it. Or D. This can be caused by a genetic mutation, certain medications, or by other underlying conditions. The doctor may be able to give you more information once he orders some more testing. Pause the video to check your knowledge. The answer is D. PAH is a very rare disease. It does affect women in their 20s to 40s. It is not contagious, and it is caused by genetic mutations, certain medications, illegal drug use, or by other underlying conditions like congenital heart disease, HIV, or lupus. After testing and reviewing the patient history, the doctor may or may not be able to tell her what caused her PAH. It may be idiopathic. And here are our references. So thank you so much for listening to our lecture on pulmonary arterial hypertension.